A todos, nós vamos dar início à nossa reunião de hoje, no nosso Grand Round, e é com muito prazer que nós vamos ter um Grand Round conjunto com a Duke University, e thank you very much for your participation, everyone, and now I will, e agora eu vou chamar o Dr. Ivan para conduzir a reunião de hoje. Ivan, muito obrigada.
Obrigado, Nilva. Good evening, everybody. We're going to start tonight's grand round with the special participation of Duke University, Duke Eye Center. They're going to present the first case, and their faculty is here with us. It's a pleasure to have them with us for discussion of this case, and are invited for discussion of the second case of this night. Thank you very much again for joining us. Kevin, you can start your case, please. You can share your screen.
All righty, that sounds good. All right. And so thank you guys for inviting us over. We're very happy to be here. The case that we're going to discuss today is entitled, Where Did Those Bubbles Come From? A case of high intraocular pressure. My name's Kevin Jackson. I'm one of the second-year residents at Duke Eye Center. We don't have any financial disclosures. And so our case starts with a 54-year-old female who presented to the emergency department with right eye pain, eye pressure, and seeing white spots intermittently. Her symptoms have been present for about 2 weeks, but have been worsening over the weekend. In terms of her past medical history, mainly just notable for a sickle cell trait. In terms of her ocular history, she does say she was mugged at age 16 and took over significant trauma to the right eye. And then unfortunately, she also experienced domestic violence 4 months prior to her presentation, and also said that there was repeated trauma to the right eye. In terms of her ocular medications, she was previously on Cosopt, which was prescribed twice a day, but the patient reports taking more frequently than that. And so her initial eye vitals, visual acuity was light perception in the right eye, 20/25 in the left eye. In terms of her pupils, there was a possible APD on the right. Her pressure was elevated to 32 on the right, 20 on the left. And in terms of confrontation visual fields, she had a complete deficit on the right. In terms of her slit lamp exam, it was mainly notable for injection of the conjunctiva on the right. There were some large chorotic precipitates in arched triangle, as well as some microcystic corneal edema on the right. In terms of her iris, she did have some superior posterior synechiae. And in terms of her lens, she had a white cataract on the right and about 1+ NS and cortical cataract on the left. In terms of a posterior exam, we did a B scan, which didn't show any vitritis or retinal detachments. And then in the opposite eye, we saw a cup to disc of about 0.7 and the retina was attached. And so now the first thing we started thinking about, what's really elevating this pressure? So we have a patient with unilateral elevated IOP. She has a history of eye trauma, and now she also has chorotic precipitates on exam. And so we were thinking, what would be the differential diagnosis, just going from here. And so what we did is we broke it down into 3 different areas, inflammatory causes, lens-induced glaucoma, or even anatomical causes for glaucoma. In terms of inflammatory, we were first thinking about uveitic causes, so that can be HSV commonly, but also other viral causes like VZV or cytomegalovirus. Also things like sarcoidosis, toxoplasmosis, and syphilis could still be on the differential.
And tuberculosis.
And tuberculosis, you're correct, Dr. Carlson.
Yeah, the one thing I would say about that is that the unilateral elevated acute intraocular pressure associated with inflammation stereotypically is either herpetic or toxoplasmosis. Sarcoid or syphilis or any of the other uveitic diagnoses would be more associated with either peripheral anterior synechiae or posterior synechiae or something that's causing an occlusion of the pupil or in the angle, as opposed to a primary elevation in pressure, which those three conditions will cause.
Yes, correct.
And then also heterochromic cyclitis or is another one.
Yes, and so the much more rare causes could be the glaucoma cyclitic crisis, as well as Fuchs heterochromic uveitis. In terms of lens-induced causes, the common ones that we get tested on our boards: phacoanogenic, phacolytic, phacomorphic, and lens particle. Although again, they're not specifically shown on our slit lamp exam in terms of having a ruptured capsule or anything like that. In terms of anatomically, there's always a case of pupillary block, although she only had posterior synechia superiorly. Again, she does have this history of trauma, and so I hadn't reported any of the gonioscopy results so far, but theoretically she could have angle recession, and this could be kind of long-standing as well. And then other causes of secondary angle closure, again, which could be helped out by gonioscopy. And so in terms of our current management options,
Can I just interrupt for 1 second? Before you go on to management options, one of the things, and I don't know, maybe you're going to get to this on the exam, before you start managing it, is you really need to make sure that there isn't posterior involvement with something like herpes, which can cause acute retinal necrosis syndrome, herpes simplex or zoster, or even toxoplasmosis, because the treatment would be totally different for an infectious etiology. So you really need to, if you see an acute rise in pressure like that associated with keratotic precipitates, you need to look in the back of the eye carefully and make sure you're not missing a infectious retinitis.
Yeah, that makes a lot of sense. So in terms of our current management so far, we added on Alphagan in addition to the Cosopt. We also gave the patient a trial of Diamox to try to improve the intraocular pressure. However, the patient did report having feeling like she was having a sickle crisis on the Diamox, so we had to discontinue that. And then in terms of the next thing we were thinking about is what would be the next steps going forward. So we thought that kind of we're at the end of our medical management. So what potential surgical management could we do? So in terms of a trabeculectomy, or doing a Barrevelt valve, or potentially doing an Ahmed valve with cataract extraction. And kind of to your point, Dr. Jaffe, doing a cataract extraction to get the white cataract out, hopefully to allow us to look into to get a better, good view of the back of the eye to make sure nothing else is going on. And so in terms of the way we were thinking about it, we decided to proceed with an Ahmed valve with cataract extraction. We chose the Ahmed valve over the Barrevelt just because of the fact that this patient did have a lot of inflammation going on, and believing that we were going to have potentially a better post-op outcome and less chance of post-op hypotony with a valved glaucoma drainage device.
So Kevin, let me make a comment here.
Yeah.
The couple of things to keep in mind here. One is if you get an acute rise in pressure from uveitis, you want to look in the angle also, because even you had KP on the corner endothelial surface, but sometimes you don't have that. And if you look in the angle, you can actually see KP in the angle itself. And the reason that's important, because even subtle degrees of uveitis that directly affect the trabecular meshwork can cause rapid rise in IOP. And actually, they're exquisitely responsive to steroids. Pressures will come down very quickly within 24 hours if you treat them with steroids. The second thing, just to bring up here, you're absolutely right. Why would we pick an Ahmed over a Barvelt? A Barvelt's a bigger surface area, has better long-term outcomes in terms of controlling pressure. But the big issue that we don't know in a uveitic patient is what the actual aqueous production is. And in particular, in patients that have posterior segment involvement that involve particularly pars planitis, they don't produce as much aqueous as other patients do. And so those you have to be really careful about, because you put a Barvelt in, they will become hypotenuse. And the ones that really become hypotenuse actually are sarcoid uveitis. And so sarcoid uveitis, we tend to use Ahmeds quite regularly, or preferentially, I should say, over those. The reason we don't do a trabeculectomy is because if you have active inflammation, that's been shown to decrease the long-term survival of the trabeculectomy.
Great. Okay. And so we actually wanted to have the patient come back shortly as we were planning the cataract surgery. And on her repeat examination, we actually found that the intraocular pressures were now actually elevated in both eyes, 31 in the right and 35 in the left. And then on repeat examination, we actually found that there was now cell noted in both eyes, so active inflammation, as well as a few KP on closer examination in the inferior portion of the left eye as well. And so now we felt that we were dealing with active anterior uveitis. And so kind of going down what Dr. Jaffe had mentioned earlier, we really wanted to make sure that there wasn't an active infection or something like that causing this uveitis in this patient. And so we did an initial workup, which included the lab test noted here. Unfortunately, that workup was actually negative. So nothing came back positive. So we didn't have a direct cause for the anterior uveitis. However, we did want to get it under better control. And so as a result of that, we did start the patient on aggressive steroids, as well as continued the glaucoma management, and then really wanted to get her into the operating room to finish that surgery so that we can get a better view into the posterior segment.
And I probably would have done an AC tap for PCR as well, at either when they first presented or if you were planning on doing the cataract surgery right at that time.
Glenn, is 6 times a day Pred Forte sufficient, or would you go higher?
Yeah, I almost always use hourly Pred Forte if there is 1+ cells or more, or every 2 hours Durezol, or if there's less than 1+ cells, occasional cells, I might go every 2 hours, but I like to hit them really aggressively in the beginning. And then it makes it easier to get them under control and tapered, as opposed to treating them sort of halfway, and then you often are chasing your tail. So my preference is to treat more aggressively. And yes, I would, if you think it's inflammation that you're treating, and both to treat the inflammation and the pressure, I would have treated every hour.
Glenn, any thought that this might be a manifestation of a systemic malignancy at this point?
That would be pretty unlikely. I mean, I never say never about anything, but I don't know what malignancy would present like that.
Okay.
One of the fellows popped up a question here. What do you think about starting an antiviral right off the bat?
I think that's not a bad idea. The reason for doing it would be to cover them while you're waiting to get the results of your PCR. So I would have done the PCR, like I said, and then putting them on an antiviral is not a bad idea while you're waiting to get the results. And then once you get the results from your AC tap and you've had a chance to look at the back of the eye, once you take the cataract out, then you could stop it if there was no sign of herpetic involvement.
Great. And so in terms of 2-week follow-up for the patient, her anterior uveitis had been improving. However, her IOP was still elevated at 28. And so
excuse me, may I ask some questions? As Augusto Paranhos here from Brazil. I understand that at the beginning, the IOP for the left eye was 20 and the excavation is 0.7. Have you ever tried to do a visual field on this one? See if it's something that is going on chronically in this patient? Do you have you have the photo of the op disc or even the photo of the anterior chamber of the right eye? I'm missing these informations.
Yeah, sorry about that. Unfortunately, in these first visits, they were kind of all like urgent visits, and the patient wasn't able to stay for the formal, a full formal exam with slit lamp photos and with Humphrey visual fields and OCTs and things like that at these initial examinations. So yes, we are missing those things.
Do you have any idea if there's now that you're following this patient, if this is already a bilateral glaucoma or is just asymmetric glaucoma with acute case in the right eye? What is your impression on that?
Now, after following her for a long time, it looks like she definitely has uveitic glaucoma in both eyes that was affecting both eyes.
Yeah, but it was not beginning now. I mean, the right eye is not just while you're following the right eye, it just starts something in the left eye. It's something that had happened in the past in the left eye also. Do you think so?
I think
that the gonioscopy for the left eye? Is this clear? Is there a lot of pigments? Is there any sign of inflammation from the past? What, do you have any information?
The only sign of inflammation in the past in the left eye was the chorotic precipitates. In terms of the gonio of both eyes, the angles were open. There wasn't noted, any chorotic precipitates specifically in that eye, but I definitely think that our initial impression was that likely she had probably been having some form of inflammation probably prior to what she was currently experiencing right now.
Okay.
All right. And so then I'm just going to really quickly just mention intraocular surgery in an inflamed eye. In an ideal situation, we obviously would want the eye to be quiet for 3 months. However, in acute settings, we do have to sometimes do surgery in an inflamed eye. And so that brings up the topic of perioperative steroids. And so a lot of times it can vary institution to institution and by provider. In this case, what we did was we'd use oral steroids, 1 milligram per kilogram per day, 3 days prior to surgery, then gave the patient IV solute Medrol 1 gram at the time of surgery, and then started her on a taper 10 milligrams per day per week until she would finish that. And then obviously we then increased her Pred Forte to Q1 hours in the right eye after surgery to really aggressively try to control that inflammation in the postoperative period. And so then we proceeded with the cataract extraction and Ahmed valve insertion for the right eye. And so on post-op week 1, vision improved 20/25 in both eyes. Pressure was better controlled in the right eye. However, unfortunately, the IOP in the left eye had increased again, now up to 38. She had the Ahmed valve in place. And then in terms of the dilated exam, we just noted the cup to disc of 0.6 and 0.7, but to Dr. Jaffe's point, we were able to get a much better view of the retina obviously now, and there were no signs of any viral retinitis or past sequelae of retinitis or anything for this patient at the time. And so just to recap, we're now 2 months into the treatment for this patient. She initially presented with an elevated pressure in the right eye and then in both eyes. And then we saw signs of active uveitis. She had initially improved IOP control in the left eye with just maximal medical therapy and steroids. We then proceeded with cataract extraction of the right eye, but now the IOP is again elevated in the left eye. In terms of the medications that she's on Cosopt and Alphagan in both eyes. She's on Pred Forte 4 times a day, and she's still tapering the PO prednisone. And she's just on ofloxacin with a bandage contact lens as post-op for her post-operative course for right now. And so because of the continued elevated IOP in the left eye, we did decide to proceed with Ahmed valve in the left eye as well. And so after doing that, she had an uncomplicated post-op week 1 visit. In terms of her post-op month visit, vision was 20/30 in both eyes. Pressures were in better control, 16 in the right, 21 in the left. Her AC was quiet on the increased steroids as a result of the surgeries. It was noted that she had improved chorotic precipitates in both eyes. In terms of her medications, she was on Pred Forte 6 times a day in the right eye, and you'll remember that that was a surgery that we actually did earlier. The reason for that is she's actually been followed with a uveitis. She was continuing to be followed by a uveitis specialist and was continuing to have recurrent CME. And so they had her on Pred Forte and Ketorolac in hopes of helping to better control that cystoid macular edema. She was still continued on both of her glaucoma drops as well. And so over the next interim, she continued to make her retina appointments for the refractory CME. However, she unfortunately missed a few of her repeat glaucoma follow-up appointments. So unfortunately, the next time point that we get from her from a glaucoma standpoint is actually at month 8. She comes back, her vision's 20/40 in the right eye, 20/25 in the left eye. Pressures are in the mid-teens. The AC is still quiet at this time. She has the PCIOL in the right eye, and then she's having a progression of her cataract in the left eye, likely as a result of being on the increased steroids. And again, in terms of her fundus exam, the cup to disc has remained stable. In terms of her ocular medications, we still have her on the steroids in the right eye, basically the same management as we're continuing to try to get the CME under control. And now, given the fact that she's continuing to have kind of borderline pressures and the fact that the cataract is progressing, we're thinking about having cataract surgery in the left eye, but we're hoping that that left eye can get quiet for a longer period of time before we go back in for another surgery. And finally, at this time point, we were able to get baseline OCT and Humphrey visual fields for the patient. And so taking a look at her OCT here, in terms of the right eye, we did see a few areas of superior temporal and inferior temporal thinning. And then in terms of the left eye, we did see a definitive area of superior temporal thinning, but overall not very far outside of normal. And
Actually,
then in terms of,
would you mind go back to the OCT?
Yeah.
It not seems that's thinning. It's just that the nerve fiber layer is tilted to inferiorly, temporally inferiorly, but it's normal OCT. It's a typical rat disease on this one, because you see the spike of nerve fiber layers inferiorly, not inferior temporally. So I cannot say that this is actually a normality.
Yeah, we would agree. They, Dr. Gupta, who was also doing the case, also mentioned the same fact that potentially this could be just kind of the variation of how the nerve fiber layer is going.
But for the right eye, yeah, for the right eye, you can see superiorly. There's a, even if it's in the limit here, the inferior limit, there's a typical symmetry between superior and inferiorly here in the right eye. Right. Not in the left, right?
Yes, you have a superior thinning, very established superior thinning. I also think that the left eye has a artifact like a red disease because of the situation that Paranhos just explained.
We would agree.
Okay.
In terms of the visual field, looking at the left eye, it's a 24-2. It's fairly good reliability. In the left eye, there was potentially from the visual field, it looked like possibly there could be an early superior arcuate, but also it could just be the first baseline test, so we would need more for that. In terms of looking at the right eye, there was a little bit worse reliability, but still moderate. And there it did look like there was a superior nasal step as well as possibly an inferior arcuate defect for that patient.
Is this the only visual field, or you have another one?
This is the only visual field that we're presenting for that.
So you have to repeat that to see if it's really something happening or not.
Exactly. Yeah, we would definitely have to do that. And so after finally getting that first time point, we then wanted to have her come back for another visit, obviously, and we had her rescheduled. Her visual acuity was 20/40 in the right eye, 20/30 in the left eye. Unfortunately, her IOP in the left eye was now back up to 34. In terms of her anterior chamber, I apologize, I don't have it listed here. It was still quiet. There wasn't any signs of repeat inflammation in the eye. There was concern that potentially the glaucoma tube could be failing. And given the fact that we were already planning to do cataract extraction, we wanted to potentially do a cataract extraction and a revision of the Ahmed valve. However, to temporize her over, we had her on her normal ocular medications, and we started another medication called Repressa to kind of hopefully get the IOP under control while we can kind of maximize her for surgical therapy in the near future. And so unfortunately, 2 weeks later, she actually shows up for an urgent visit. The vision in the right eye is 20/25. However, the vision in the left eye is up to 21, is worse to 21/50. The IOP is still elevated at 38. At that time, we did an AC tap and added neptazane to try to bring the pressure down, and it improved to 20. In terms of her slit lamp exam at the time, we were able to get photos. And this is a slit lamp photo of her left eye. And so I just want to draw your attention to the inferior portion of the cornea outlined in this blue line here. And basically note that from about 4 o'clock to 8 o'clock, she has this inferior epithelial reticular corneal edema. And then here is another photo with indirect illumination, really highlighting this area of reticular corneal edema that's new for the patient. In terms of the exam, it's basically just, again, noting the things that I had mentioned in the photo. And so in terms of management at this time, she has an elevated IOP in the left eye despite being on maximal medical therapy. So we were thinking about what are the next steps as she's here for this urgent visit. And so potentially we could continue medical management, just continuing all the drops with the neptazane. We could discontinue the Repressa, which we had added to try to help improve her IOP control. Also, we briefly mentioned discussing ECP of the left eye, or we could proceed with cataract extraction and then replacement of the aqueous shunt with potential graft revision.
Kevin,
And
can
so
you
yep.
can you back up to those pictures again?
Yeah.
I don't think we really covered what is causing that. Do you want to, or are you covering that later?
Yeah, I'm going to get to that later.
Oh, okay. I'm sorry.
No problem. And so,
Is it? Sorry.
yeah. And so continue all other medical management and proceed with cataract extraction. And so after cataract extraction, the vision again improves. The pressure is better with the new Ahmed valve. And now she has a large bleb. The AC is quiet in both eyes. This is a slit lamp photo taken just after that visit. And as you can see, the reticular edema that was present inferiorly in that left eye has now resolved. And so now going to Dr. Chawla's question.
Oh, quick question, Kevin. So what did you do to the Ahmed to improve the function of the valve, of the implant?
I believe that it was actually one second. I believe that we actually replaced the Ahmed valve.
Okay, so they thought it was a primary failure of the Ahmed implant, which is quite rare actually, but it does happen. So if you don't have flow through the Ahmed valve, then the clues to that is that the bleb is flat over the plate. Normally you'd expect a bleb over any of the implants. If the fluid's not there, or you can't lift the lid up high enough to see it, then you can do an ultrasound, look to see you have fluid around the plate. If that's not present, then you have to wonder whether it is primary valve failure, and it can occur for a couple of different reasons. One of which is as you're putting the implant in, if you grab the valve mechanism with a pair of forceps, you can cause micro cracks in the valve mechanism, and those micro cracks now fibroblasts can now adhere to them, and they can actually grow into the valve mechanism and cause a primary blockage of it. Sometimes you can just simply excise that fibrous tissue, pull it out, and then get refunctioning of the implant. But sometimes if it's a primary valve failure where the valve is just not working, then you have to replace the whole implant.
One thing I might consider, Pratap, if you're going to replace the valve, I would consider maybe a non-valve device, a bar valve, a smaller device, 250 square millimeter. Yeah. I've seen good success in those circumstances.
Yeah, great suggestion. Yep.
Yeah. Kevin, may I have a question? Did you replace, you put another Ahmed in the same quadrant or in a different quadrant? I didn't get that.
I believe it was.
I think it was the same quadrant.
I believe it was
the same quadrant.
Yeah.
We don't use to do that. We think you have more failure when we do in the same quadrant. I would go with Dr. Ardon. Would put a bar velt or even an Ahmed in another quadrant, but a bar velt would be a very good option. Yes, I would do a bar velt.
Makes sense.
You can actually put a bar velt back in the same quadrant. It just takes a lot more dissection to do that. Sometimes we've done that as well. Yeah.
Yeah.
So then getting to the next point of basically figuring out what caused the reticular edema to begin with, and likely contributed to the fact that her vision decreased to 2150.
I believe Kahuk described this recently, this cornea alterations with the Repressa, probably it's that. I have a patient that had something very similar as well, and we think it was caused by Repressa.
Yep, and that's what we believe as well. So Repressa is a fairly novel glaucoma drug. It's a Rho kinase inhibitor. And Rho kinase, as we know, is involved in regulation and modulation of cell shape and size and action on the cytoskeleton. And it's also believed to be involved in focal adhesions in the trabecular meshwork. And so inhibiting that might improve outflow. And the mechanism of action is believed to be threefold: increasing outflow of aqueous humor through the TM, decreasing episcleral venous pressure, as well as decreasing aqueous humor production. And the indications for Repressa's use are currently glaucoma, with studies saying it has a similar efficacy to timolol, but also in areas of cornea in patients with Fuchs dystrophy. The fact that Repressa seems to kind of stimulate the corneal endothelial cells and help them function better to help remove some of the corneal edema. as well as other patients with general decreased corneal endothelial health. There have actually been case reports published where patients have just had a desmetorexis and then actually started on Repressa, and their own corneal endothelial cells will then start working better and help repopulate rather than needing a new DSEC or DMEC graft. But obviously these things are still very, very early. And so I just had a few other cases that had been reported in the literature of Repressa associated with the epithelial edema. These are 2 cases from a ophthalmologist in Virginia. And you can see very nicely in his anterior segment OCT that this reticular edema is really loculated in the epithelium, and that the stroma actually looks fairly dry without any edema. And so this was in a patient that had a failed DSEC, and they were on Repressa for 5 days when this developed. And in that case, when the provider saw it, he actually stopped. He did a superficial therapeutic keratectomy and regraft. In another case, there was a partially detached DMEC. And again, you can see in this slit lamp photo that the edema still seems to be just in the epithelium, and left the patient on Repressa for 11 days. And then 15 days later, there was resolution of the edema, but the patient was actually, in this case, kept on Repressa, but the edema still did resolve. And so the etiology actually for Repressa and the epithelial edema still hasn't really been characterized that much in the literature. But again, as to your point, Dr. Tavares, there are still more and more case series continuing to be published describing the similar findings of having patients on Repressa and them developing this epithelial edema. And so in terms of our hypothesis on what we think might be going on, is that the patient developed increased intraocular pressure that somehow resulted in a diffuse level of corneal edema. We then started the patient on Repressa. Repressa stimulated the corneal endothelium to kind of work better to try to help pump out some of the edema from the stroma. However, because of Repressa's other effects, there ended up being kind of a tightening of intracellular junctions, specifically kind of in that epithelial area. The endothelial cells, as I said earlier, remove fluid from the stroma, and then the epithelial edema actually kind of gets locked into that area. However, in terms of the jury seems to still be out on do patients really need to be stopped and taken off of Repressa, or can they just be continued on Repressa as the patient in the previous case series? And eventually that edema starts to work its way out or just distribute throughout the cornea and no longer cause any problems. For the majority of the case series, most patients, whenever this happens, are taken off of Repressa. In our patient specifically, they had a lot of pain and decreased vision as an association with the Repressa, and so they didn't want to be continued on it, and they didn't want to have a retrial of it to see if this is something that would continue to happen for her, or if it was just kind of a one-off because her pressure was elevated when we initially started it.
So Kevin, let me stop you there. So I've seen this, your studies support 5 days. I've seen this at the one drop.
One drop.
Rocklatan. I had a patient, monocular patient with corneal edema who actually Dr. Gupta saw for me the next day. Devak, I'm not sure if you want to comment, but because you published on this as well, Devakar, but does she have the reticular pattern? Yeah, I think you know the patient I'm talking about.
Yeah, this is Devakar. Yeah, she did have that reticular pattern that I've seen with other patients that have had the Repressa-induced reticular corneal endothelium. And in that patient also, she had some increase in her eye pressure as well.
Right.
It's interesting. I've seen this several times too, and I think it happens more commonly than we think, because we ask the patient to start the drop and then come back after 4 to 6 weeks to recheck the pressure, so we probably miss it. Most of the patients doesn't seem to cause as much vision disturbance as it does in this patient, as it did in this patient, sorry. But if you leave it, the Repressa, this actually goes away and resolves. I've not seen anybody have it persist long-term. The one thing it does seem to do is, the handful of patients that I have, they have all ended up with corneal verticillata also later. So I don't know whether we can sit down and think about ways to tie in the mechanisms together with all that.
So we don't have this problem in Brazil because we don't have the drug here. But I'm very interested about the pathophysiology of the of the corneal edema. So if I understand well, all the patients that has a subclinical stromal edema is in a risk factor to have this epithelial edema, reticular epithelial edema with repressor. Is that correct? Is it like a risk factor for them?
It's not clear. I have low tension glaucoma patients have done the same thing where the pressure start out low.
I mean, the
Add a
corneal
repressor.
edema. It doesn't.
Yeah.
I'm not saying that is because of the IOP. I mean, any corneal edema, like a Fuchs patient, if you try this, you could have more epithelial edema, or it's not the case?
I've not observed that. How about you, Leon?
Not other than the patient that I talked about had that just one drop did have Fuchs edema, about 1+ edema. So she was predisposed, if you will, to issues with her cornea.
I've seen several of these cases. In fact, we've recently submitted, I think Ellis is first author, a series of patients with this, particularly the post-DMEC DSEC patients. And one of the really interesting things I've seen in the DSEC DMEC patients is that this reticular edema occurs in the peripheral cornea, and it goes right up to where the donor tissue is. And when the donor tissue is fully attached, it doesn't go over that. It stops right there. So we're not sure what's going on there, but it's an interesting observation. I have one patient who's wanting to hold off on a repeat DSEC procedures that she had years ago. And especially with her age and the pandemic and everything. So I went ahead and put her on Repressa twice daily, and it seemed like it put her, it improved some. She has, better days than before, and she's happy with holding off on the repeat procedure. So that's been a plus. Apparently there's an analog out of Japan that has a similar mechanism, but seems to work better with regard to the loosening up the tight junctions between the endothelial cells. We just don't have access to that medication. But in other countries where they're doing DWEC surgery, that's the removal of Descemet's without a donor tissue, that's been a helpful agent in helping those patients recover. In this country, those of us that have started doing that procedure have been using Repressa.
So you think, Alan, sounds like this may be more if you have a pathology of the corneal endothelium, you're more likely to get this. Is that what you observed?
I think so. I don't think it's going to be for your Fuchs patient who has the posterior collagenous layer, that extra layer of collagen between Descemet's membrane and the endothelium. But I do think it's helpful in those patients where you've removed endothelium and you've removed that posterior collagenous layer. I believe this helps the migration of endothelial cells into that barren area and helps these patients recover more quickly.
We should probably sit down and talk, because I don't know if Repressa, actually the whole company is a spin out of our department here. It was started by David Epstein. So the basic science research for that work came out of our labs here with Vasanth Rao. And David Epstein actually saw it all forward to forming a company and bringing this treatment out. But yeah, we should probably sit down and think about it, because we'd certainly have the tools to study this, to figure out if that's the case or not.
That'd be great. Cornea people are very interested in this drug right now.
As Parayan said, we don't have these drugs here in Brazil, but we have a couple of patients using the Japanese drug. And one of them had the same clinical aspect of the cornea with the Netazorgil, that is the Japanese drug. And it's very similar. Is a patient with silt foliation glaucoma and with Fuchs dystrophy. And developed these alterations in cornea in both eyes. Yeah, yeah, it's with the Japanese drug, not Repressa.
Alrighty, just to finish things out in terms of her month 26 exam. So now 2 years out from when she first initially presented, vision was 20/25 in the right eye, 20/20 in the left eye. Pressures are well controlled in both eyes at 9 in the right and 14 in the left. She still has the AMEDs with a large bleb in the left. Her ACs are quiet and her cup to disc is stable at 0.7 in both eyes. So lastly, just in terms of some take-home points, one of the main reasons we all got into medicine is that there's always continued innovation, and there's always going to be novel drugs and medications in development, and the clinical trials are obviously there to assess for the efficacy and side effects of those medications. However, trial results can definitely differ from what we see in real life. And so interestingly, the ROCKET studies, which looked at Repressa, never specifically noted the corneal edema findings. They did notice an increase in injection. And so as physicians, we have to remain vigilant in the care of our patients. And so taking care of them when we're using new drugs and just being on the lookout for new side effects that we might not have already heard about, and studying them and getting a better understanding of what's going on. Repressa still obviously has great potential in both glaucoma and cornea, so it'll be interesting to see how this drug continues to be used. I just want to say thank you to Federal University of Sao Paulo for inviting us to come. Thank you to Dr. Gupta and Dr. Chawla for serving as my mentors, and Dr. Liu and Dr. Graywall and the Duke Eye Center as a whole. Thank you guys so much.
Thank you very much, Kevin. It was a fantastic case. All these uveitic glaucoma are challenging cases. All of them are difficult with a lot of comorbidities and a lot of things to be treated. And they require shunts like RMED or Barvelt that sometimes combined with fake emulsification as the first eye of this patient. They are really challenging cases. Congratulations, it was a very good presentation. Thank you very much for all the faculty that joined us tonight. And it's open for questions and comments from Duke and our faculty as well.
Ellis just added the link for the case series of 6 patients that were published a couple months ago. It's in the chat section.
Yes, it's in the chat. Thanks. Great. Augusto, Paulo Augusto, Luis, any more questions or comments?
The only thing is coming back to the case itself. I'm not sure if trabeculectomy is contraindicated for in this kind of case that you have both eyes with the same problem. I like to do like one eye trial, and one is tube implanted, the other one is trabeculectomy. I did not see the case, did not see the amount of inflammation that you've seen, so it might be a huge inflammation to avoid trabeculectomy. And for some patients that we perform a tube implant in the past, that because the inflammation was really high, and afterwards the inflammation is not so high anymore, so important anymore, we do a trabeculectomy after a tube implant, and it works very well. So there's no randomized clinical trial. Actually, there's some randomized clinical trial comparing trabeculectomy and tube implants for uveitis, and actually there's no clear a way to perform, and we are more likely to do tube implants when the inflammation is very important, and you do trabeculectomy when inflammation is not important or is a chronic case. But I understand that's an acute case. But I'll try for the second, for the left eye, if the inflammation is not so high, even if a tube implant was performed, I'll try to do trabeculectomy in this case. Because we have some patients that we do trabeculectomy after a tube implant when inflammation is not so important, and it was very okay. So it's simple. And if it does not work, it's not a huge problem to do another surgery after that, because removing the tube implant and putting this in the same site of the tube implant, and considering that it's a glaucoma secondary to inflammation, it's not a simple thing to do. So I like to do my traps.
Yeah, good point. If the conj is healthy, let's say you put a supratemporal tube in, your supranasal quadrant, as long as the dissection hasn't gone in that area and caused a lot of scarring, yeah, the traps could work quite well, actually. So I think your point's a good one.
Any more question?
No, I only can say congratulations, especially for the happy end of a difficult case like this one. Congratulations.
Thank you.
We all like happy endings, don't we?
Yes. It's not that common in glaucoma and retina then.
No.
And uveitic glaucoma.
Yeah. Yeah.
Okay, folks. It's a pleasure to have you guys with us. Leon, Pratap. Felipe Medeiros is a good friend, and some of our fellows are his fellows now, are in Doha, exactly now, working with him. It's a great pleasure to have you guys from Duke with us tonight. And you are invited to stay with the next case. It will be presented in English, as I said initially, and to discuss, to comment as well.
Thank you.
Thank you.
So good evening, everybody. Can you hear me?
Yes, Franklin.
So good evening, everyone. My name is Franklin. I'm a second-year resident from Escola Paulista. I'll be presenting you tonight's second case, acknowledging my preceptor, Dr. Luis Guilherme, and Dr. Luis Alberto, the Chief of Division of the Glaucoma Division. So the case is about a 20 years old female patient who presented with a light ocular pain in the left eye for 6 months associated with photophobia. She refers low visual acuity in the same period, but she associated this with the loss of a contact lens in this eye, which she used because she had a keratoconus. Okay, she had an unremarkable past medical history and also past family history. So her ophthalmologic exam, in her right eye, she had a best corrected visual acuity of 20/40, and in her left eye, she had a visual acuity of counting fingers. I will show you the photos of the anterior biomicroscopy. Her intraocular pressure was 12 and 39 in the left eye. Her gonioscopy of the right eye was an open 360, and I will show the photos of the left eye and also photos of the fundus exam. So this is the anterior biomicroscopy of the right eye. Should I go on?
Yeah. Yes, you may go ahead, please.
Yeah. So there were normal eyelids and eyelashes. She had a diffuse conjunctival hyperemia due to contact lens use, clear cornea, trophic iris, and phakic. In the slit lamp, we see a formed anterior chamber and phakic. So this is the left eye photo. We see a diffuse conjunctival hyperemia. The cornea appears to be clear, but I saw the patient. It was she had a biotch corneal edema. It's hard to see in the photo. She had a superior correctopia and ectropion uvei in the superior area, and we can see these iris pigmented nodules in the superior region of the iris. We can also see some regions of iris atrophy inferiorly. So in the slit lamp, it's very hard to see in the photo, but she had a very mild corneal opacifications. We can see in the slit lamp, and she also had this very light edema. Here we can see the keratoconus, the corneal protrusion. In more details, we can see the iris nodules here. So hyperpigmented nodules and located superiorly in the iris. Here in the gonioscopy, we see peripheral anterior synechia in all quadrants. We can see it's essentially a closed angle, okay? So in the right eye radiography, we see a pink optic with sharp margins, excavation of 0.3, normal vessels, normal macula, and attached retina, essentially a normal right eye. And here in the left eye, we see a pink optics with sharp margins, cup to disc ratio of 0.9 to almost total excavation, normal vessels, normal macular attached retina. Here in more details, and the photo is not very clear because of the corneal edema, but we see a very big excavation. So for the diagnostic hypothesis,
I'm going to call Gabriel, third-year resident, please.
Good evening, everybody.
Hypothesis.
Yeah, so we are with a patient, 28-year-old patient, I believe, with unilateral high IOP and suspicious optic disc for glaucoma. So I would think about diagnostic hypothesis for unilateral glaucoma in a young patient. I would rule out at first juvenile glaucoma because it is unilateral. Also, Axenfeld-Rieger syndrome is also should be bilateral, so not think on those hypotheses at first. We have always have to think about post-uveitis glaucoma in young patients, but she doesn't have any signs of uveitis in this eye, so this isn't a strong hypothesis either. Also, secondary to corticosteroids, she has keratoconus, so I don't know if she ever used corticosteroids for her allergy, maybe, but we don't know that information. And in this case in particular, eye syndrome is a very strong hypothesis because of the iris alterations. Frankly, showed the peduncular nodules in the iris and also the close angle. So I would definitely think of eye syndromes, in particular Coogan-Rees syndrome because of the nodules. She doesn't have a very important corneal alteration or very important iris atrophy to think of the other two subtypes of the disease. So
very well. So she had a keratoconus and a unilateral glaucoma with corneal and iris alterations. We always have to think of a secondary glaucoma when you have a unilateral case of glaucoma. And because, as Gabriel just said, the corneal and iris alterations lead us to think about eye syndrome, more specifically Coogan-Rees syndrome, because of the iris nodules. So the case doesn't leave much room for other diagnostic hypotheses. I think it's a very direct diagnosis. So for the management.
Any comments before the management? Someone want to talk? Okay. Go ahead, Gabriel.
Comments about unilateral or asymmetric keratoconus, and that is that these tend to be eye rubbing patients. And if you ask the patient, show me how you like to rub your eyes, they'll give you a puzzled look. But then if it's unilateral, they will always they'll always say, in this case, reach up with their left hand and rub that eye. If it's bilateral, people will reach up and do this in almost every case. And when it is significantly asymmetric, about 85% of those patients will sleep on that side, and they like to push their pillow into their eye. The old thinking was that keratoconus patients are more likely to have allergies. Oh, and that's true. allergic patients are more likely to rub their eyes. True. Therefore, keratoconus patients are more likely to rub their eyes. False. The eye rubbing that is associated with allergy it's an XY axis rub. I don't know if you can see me on video, but they like to do this. It's back and forth, and then they'll take their finger and they'll go in on the caruncle, okay? The eye rubbing for the keratoconus patient is a Z-axis rub. They will actually take their knuckle, they'll push in deep, and they'll rotate it. When you ask an allergic patient why you rub your eyes, they'll say, I rub my eyes because they itch. If they didn't itch, I wouldn't rub my eyes. The keratoconus patient will have an almost ecstasy effect when they rub their eyes. They can rub their eyes for up to 5 minutes when nobody's around and looking. So it's a pleasurable thing that they do. And when people have advanced keratoconus in both eyes, they'll sleep face down because it puts pressure on their eyes. Now, in some cases, keratoconus is an eye disease by itself. I don't want to take away from your glaucoma discussion because I could go on for 2 hours with this, but just give me 2 more minutes. It's an eye disease. In other people, it's a susceptibility. In other words, 30 seconds of their eye rubbing may accomplish what 10 minutes would accomplish in somebody without keratoconus. In other people, it's actually a syndrome. They're more likely to have mitral valve prolapse. They're more likely to have obstructive sleep apnea. We were the very first to report that with my young resident Priya Gupta several years ago. We reported that it was a significant risk factor for obstructive sleep apnea. And also another fellow of mine, we reported morbidity. So this syndrome is the floppy cornea. They get a floppy eyelid. They get a floppy soft palate leading to obstructive sleep apnea. They have a floppy belly with their weight gain, and they have a floppy mitral valve associated with mitral valve prolapse. So in some people, it's actually a syndrome. I just wanted to add that because in my experience, the thing that jumps out here is that keratoconus by itself is not a risk factor in the absence of having surgery for glaucoma. In fact, I, along with Sanjay Asrani, think it's actually a preventative. It can actually reduce your risk of getting it. And in my weird way of thinking, I'm wondering if the cornea is a version of internal cupping. You know, you've got a normal cornea and you look to the back with glaucoma, you get nerve cupping. But in keratoconus, instead of getting the nerve cupping, you get the cornea cupping outward from the inside. Anyway, I didn't want to distract too much from that, but I just wanted to throw those keratoconus gems in there.
Very, very interesting. Different itching patterns. Okay, for the management, or the
Go on.
Okay.
Gabriel.
Gabriel?
Yeah. Yes, Gabriel.
Okay, so this patient, we don't have any complementary exams for her yet. So I would ask for the visual field. Her visual acuity is counting fingers in the left side, but I'm not sure if that visual acuity is with or without the corrective lens. So if
without,
if she can do the 24 to visual field Humphrey, it would be better. And the OCT of the optic disc and nerve fiber layer, and the pachymetry as well. And also start with the hypotensive drugs. The IOP was 39, right? So
yeah,
we already initiated with some drugs.
Yeah, we'll get there. So we first asked for the pachymetry, the visual field, and specular microscopy that I will show you. So she had a thinner cornea. Remember, she had a keratoconus. So 490 in the right eye, 460 in the left eye. Here's the visual field 24-2, no alterations in the right eye. And here in the left eye, we see a superior defect. It's almost an arcuate, we could say.
It's an arcuate, yeah.
Yeah. And the specular microscopy, we see a normal exam in the right eye. And when we compare to the left eye, we see a pleomorphism. We see the architecture of the cells is not hexagonal. We see a little bit of a little bit lower counting, but not too much. But it's especially if you see the difference between the formats of the cells. Okay, so just as Gabriel said, we started hypotensive drugs. We started brimonidine twice a day, timolol, and dorzolamide twice a day also. So she returned 1 week later with the under correct use of the medication, but the IOP just was lowered 4 millimeters of mercury to 35. So after that, we entered acetazolamide and already asked for preoperatory exams.
Excuse me, I have just a point to our, you can go ahead, you want. Yeah, to our American colleagues, that our patients get their drops, their eye drops from the government. And the government gave us the alpha again, the brimonidine 0.2, not the 0.1. And the government as well don't give us combined drugs, only isolated drugs. That's why the patient is using brimonidine, timolol, and separately. Okay.
Yeah, it's a little bit limited. So under use of acetazolamide, the IOP dropped to 30, still high, and so we decided to go on with a surgical management with a trabeculectomy with mitomycin in her left eye. This is the 6 months post-operative biomicroscopy photo. We can see a restrict bubble, a thin bubble, but elevated. Okay. And
yes, it's a very localized blab, localized blab with probably a iron ring, and you have this fibrosis limiting the blab. Then we call it the iron ring, with the steel ring, and it's you can go ahead.
It's very localized.
Could I ask a quick question? Did you do anything special with the trabeculectomy? Because one of the concerns with ICE is that the membrane, which is an endothelial tissue that has epithelial characteristics, will not stop growing, and so sometimes it grows right over the sclerostomy, the trabeculectomy. Did you make it bigger or wider? Is there anything special that you do for these?
Yeah, when we indicate trabecular crabs in these eyes, you usually do that. Larger ostium and more mitomycin, but as you said, you have a lot of failure cases because of the membrane. Yeah,
I don't for uveitis. I like to do my traps before, but for eye syndromes, I start with tube implants because it's a pre-trabecular glaucoma. So the chance that it will close is, in my hands, it's almost 100%. So I prefer to do tube implant as the first option. There's nothing wrong doing trabeculectomy because there's some papers showing that it could work with the details that you're talking. It's not in the papers, but everybody that do that try to do a larger hole to avoid the membrane to enter and close your trabeculectomy. But I prefer for this case to start with a tube implant as the first option.
Yeah, so do I. Yeah, I would go with RMED before. Yeah,
I agree with Paranhos.
So after the surgery at 6 months of postoperative period, she had a controlled IOP under use of only brimonidine in her left eye, so she had an IOP of 12 millimeters of mercury, and And that was the case. I'll quickly say a few words about ICE syndrome. So ICE stands for iridocorneal endothelial syndrome. So it's characterized by the migration of endothelial-like cells from the endothelial corneal endothelium to the iris and to the angle, and the contraction of this membrane causes not only the closing of the angle, but also all the iris alterations that we see. So we can see the peripheral anterior synechiae in the gonioscopy, the iris atrophy, correctopia, pseudopolychoria, and ectropia in uvei. We can see, as in our case, iris nodules. They are described as pigmented and pedunculated nodules. Oh, sorry. And the corneal alterations, we see this aspect of hammered silver in the opacification in the cornea, and also alterations in the specular microscopy. So we see a low number of cells and polymagatism and pleomorphism, and there is an inversion of the dark and white pattern. So the specular microscopy ends looking like an epithelium exam. And the eye syndrome can be categorized into three different variations. The first one is progressive iris atrophies. Just as the name says, iris findings are predominant. We have the Chandler syndrome, where corneal alterations is predominant, with corneal decompensation and corneal opacifications. And as our case, Coogan-Reese syndromes, characterized by the presence of iris nodules. And the two main challenges in those patients, as I said, is the corneal edema and the glaucoma more specifically. So the glaucoma may be present in half of cases, and we see a very low success rates with clinical treatment, and all of them almost end up doing in surgery. So the big discussion here, I think, is this management. Should we do a trabeculectomy or do a glaucoma drainage implant? The results in the studies show variable results in both surgeries, and it's a very controversial topic. And most of the cases, 45%, they have to go. They have to do more than one surgery as necessary. And I just want to show you this case report. It's a case report from Italy, which the patient had also eye syndrome, but with essential iris atrophy variant and keratoconus. So it's a very, very rare association. We don't think it's part of the same syndrome. They have just different diseases in the same eye. And in this particular case, the patient went under a tube implant and had success. So just to illustrate how rare it is and how variable the results are with either trabeculectomy or a glaucoma drainage implant. So I just want to bring this for discussion. What are your experiences with those patients? And thank you for your attention.
Very good, Franklin. Thank you for the presentation. We have Dr. Luis Guilherme. You want to comment, final comments on the case? And
comment here.
Sure.
ICE syndrome is typically thought of as being essentially a unilateral process, but Ramon Font and Jamie Petronelli in Houston have shown that if you look closely with specular microscopy in the contralateral eye, you'll often see some of the early changes. You know, what used to be called the epithelialization of the endothelium. That's an outdated term. But it's a little more common in Chandler's syndrome, but the other conditions can have some of those early changes as well. And that can be helpful when you're trying to sort out the differential diagnosis.
Sure, very well remembered, yeah. Luis Guilherme, you want to make your comment? Perhaps on trab versus tube in this case?
Initially, congratulations, Franklin. What I find interesting in this case is the association between two diseases that affect the cornea. I think this, in this case specifically, this can cause difficulty in the diagnosis because it was a patient that have an examination of ophthalmology examination every 6 months, because of the contact lens and refraction. And in my opinion, these iris nodules have been present for a reasonable time, and so caused by keratoconus. We focus the exam in the cornea and forget the iris. It probably was difficult to the diagnosis, but so trabeculectomy versus tube, I think there is no consensus, like Augusto said, but in our university, because of costs of a tube, trabeculectomy, it must be could be initially surgery in this case.
Yeah, great. Thanks, Luis Guilherme. Yes, another situation that you see frequently is these patients being treated as anterior uveitis. Yeah, it's not unusual. I have at least 4 patients that came with the initial diagnosis of anterior uveitis and being treated with steroids drops, and actually they had eye syndrome. Yeah. Any other comment?
Yeah, I'd like to make a comment. These are very difficult patients to take care of. And unfortunately for this patient has 2 sporadic diseases that occur together. I mean, that's a very rare thing, but it has been reported where these 2 diseases have occurred in the same patient. But with these eye syndromes, the problem is that membrane will grow over the trab. And in the past, I have tried using a YAG to open up the sclerostomy, and it does open, but unfortunately it closes back up relatively quickly. And even the tubes, when I put tubes in these patients, I try to leave them as long as I possibly can into the AC. So I put them at an oblique angle, leave them as long as possible, because the reason is that membrane will grow down the tube. And if the tube is very short, it can actually reach the end of the tube and block the tube off as well. In the tubes, using tubes that are blocked with the membrane, using a YAG to open up the entry of the tube actually works quite well, and that doesn't seem it seems to have a harder time growing over the tube than it does the natural trabeculectomy site, the sclerostomy site. The other thing too is that these patients, it's primarily a trabecular disease. The trabecular meshwork is blocked off by this membrane. A single tube implant, even a 350 bar valve, is not going to drain all the fluid an eye can produce. So these patients do frequently end up with more than 1 tube. And sometimes we even end up having to do tubes plus endocyclo to get the pressure under control. So it's the patient always has to be warned this is a lifelong issue, and that we'll be coming back and doing things later to try to keep their pressure under control. But yeah, these are some of the toughest patients to take care of.
Yeah, that's definitely a good advice to give to the patient. Yeah.
One thing I found, Pratap, is that you're right. If you place a tube in the anterior chamber, oftentimes these also can be closed off. But one space that I've been very successful with is placing through pars plana. Obviously, you need to get your retina colleague involved, and many times a corneal colleague to do a PK. But I've not had primary failure related to eye syndrome when the tube's placed in the pars plana.
Very good point.
We can, if there's any need to do cataract surgeries, a nice way to do is between the IOL and the iris, because it's because of the damage in the pupil. You have a very large pupil, so there's no problem to be in the posterior chamber between the iris and the IOL. I think it's one of the best ways to do, because you don't have to do anything in the vitreous. You don't have to do vitreous surgery, and you're far from the cornea. And I think it's the best place to put the tube implant.
Yeah, I think to place it in the sulcus is a very good option as well, if it's a pseudophakic patient, or if it needs a surgery.
In this case, you have a very large anterior chamber.
Even though I think that due to the physiopathogeny of the disease, it would be better in the sulcus if it's possible. It's not. Usually, we have very young patients with clear lens, and we do it in the anterior chamber. Yeah. Any other comment? Questions? Can we move for the next session? Then now we're gonna have the glaucoma panel. As I said, unfortunately, it will be in Portuguese, unless everybody wanna change the language in English. And our head of the glaucoma division, Dr. Luis Alberto, will present the cases, and me, Professor Paranhos and Professor Melo, Paulo Augusto, we're gonna make the panel and make the comments.
Ok. Todos estão vendo a tela? Estão me escutando? Tranquilo?
Tranquilo.
Sim.
Então tá bom. Então vamos lá para alguns casos aqui. Então o primeiro caso é um paciente de 43 anos, sexo masculino, raça amarela, não usa antiglaucomatoso, não tem história familiar de glaucoma e também não tem antecedente sistêmico relevante, tá? Então ele chegou para fazer uma consulta com a gente e tinha uma câmara anterior profunda, profundidade média em ambos os olhos, o ângulo agonoscopia era normal, e estava com uma pressão de 17 milímetros de mercúrio nos dois olhos, e tinha no prontuário dele escrito medidas prévias, quando ele foi encaminhado com 12 milímetros de mercúrio, 2 vezes no olho direito, 12 no esquerdo e 14 antes, tá? Daí foi encaminhado, e aí esse seria o fundo de olho que a gente viu nessa época, tá? Então aqui está o olho direito, eu não vou dar detalhes, mas depois a gente volta, que aí a gente vai discutir com os discutidores do painel. Isso aqui é o olho direito, esse aqui é o olho esquerdo. Aí eu queria ver do painel se a gente faz se vocês querem mais propedêutica, viram alguma coisa, quer que retorne, ou como é que é? O que é que vocês acham da situação?
Como é que é a paquimetria só, Luiz?
A paquimetria, 563 micrômetros e 560.
Tá, normal.
Isso. Eu ia pedir só para você voltar no primeiro slide, que eu estava respondendo as perguntas aqui e eu me perdi um pouco.
Esse aqui? Da retina?
Tá. Então, o caso clínico. O descritivo do caso. O próximo. Segundo slide. Isso. Tá. Obrigado.
Então, pressões normais variando entre 12 e 17, né? E aí foi encaminhado, e é isso aqui que a gente via no fundo de olho do lado direito, isso aqui é o que a gente via no fundo de olho do lado esquerdo.
Olha, por isso que cada vez eu tenho mais certeza que a retinografia deve ser uma coisa que é feita toda vez que o paciente entra no consultório de alguém. Se eu tivesse uma foto desse paciente há 10 anos atrás, esse caso tinha muito menos graça, ou até muito mais graça, né? Assim, é uma estrutura que varia demais na população normal. Você pode ser normal, você pode ser alterado. Agora, se era um 0,2 há 10 anos atrás, eu nem precisaria de campo visual para confirmar qualquer coisa, né? Então, era super... Eu acho que por conta da democratização da retinografia, ficou barato, faz digital, não precisa imprimir. Eu acho que a gente deve fazer toda vez que o paciente... Pelo menos uma vez na adolescência, adulto jovem, tem que ter um referencial, né? E ajudar muito a gente.
Quando se formar no primário, ganha uma foto.
Isso? Propedêutica para isso daí seria... é um nervo suspeito. Eu faria propedêutica completa. Campo visual, retinografia e OCT. Retinografia já tem. Faria OCT e campo visual.
Põe um esquerdo aí, Luiz. Enquanto o Paulo Augusto fala.
Vamos lá.
Pela retinografia, ele parece ter uma boa camada de fibra nervosa, né?
Era isso que eu ia comentar, Paulo Augusto.
Mesmo assim,
camada de fibra.
Mesmo assim, acho que vale a pena fazer a propedia. Tem uma certa simetria de escavação.
Mas...
O círculo linear está protegido no outro olho dele, no olho direito dele. E aqui tem uma escavação meio estranha, né? Mas tem
aqui, volta no esquerdo, Luiz. Aqui não tem um desnudamento vaso círculo linear superior, não? Eu não
Parece
consigo ter
que o olho tem bem evidente o inferior ali, né?
Não, o superior ali não tem. Bom, assim, o principal é a propedêutica que você já fez. Porque assim, você vai, em cima do que a gente falou, você pode abrir duas coisas. Ou vai dar normal ou vai dar alterado. Se deu normal, o principal é registrar como ele está para seguir. Se deu alterado, aí é um negócio... Aí você tem que...
Na época...
Aqui, a coisa interessante aqui. O que me chamou a atenção é que a gente está lendo só no nervo, mas olha, o que me chamou a atenção foi isso aqui, ó.
Aí tá além da imaginação para mim aqui, eu não consigo ver isso. Não.
Eu consegui ver,
Luiz. O mouse passando.
Tá.
Então. Mas chega no nervo, Luiz, ou é um pseudo?
Então, aqui, não dá a impressão que não chega no nervo, tá? Mas tá
dá a impressão que para nesse vaso aí, ó.
Aí o que acontece?
O linear está protegido, ele é inferior. Agora, achei um consenso que todos nós faríamos uma propedêutica completa desse paciente, né?
Então,
Luiz, agora que você apontou, eu vi alguma coisa, mas sinceramente eu não tinha visto isso, não.
Então,
eu também não tinha
resolução para...
Eu estava olhando bem peripapilar e achando a camada de fibras super normal. Eu até ia comentar que por aquela camada de fibras, numa época pré-OCT, eu ficaria... Lógico, eu pediria o campo visual e iria segui-lo. Né? Mas agora com OCT, ainda mais com OCT de GCC, né?
Já que você mostrou, agora eu não consigo deixar de ver, né?
Aí aqui, ó, no olho direito dá para ver na Red Free. Mais fácil, né? E o olho esquerdo passa liso, tudo bem.
Quem estiver assistindo no celular não vai ver, tá? Nem se preocupem, não dá para ver no celular.
Tá. Olha, então tá aqui o campo dele, tranquilo, tá? E o paciente não teve condições de fazer o OCT.
Por quê?
Porque o convênio não liberou e não tinha condições.
Para glaucoma, né? Não libera para suspeita, é uma pena.
Isso. Mas tudo bem. Eu apostei naquilo e introduzi latanopróstata. A PIO baixou. Aí vamos lá. Será que era ou não era? Oi.
Luiz, você fez um diagnóstico de glaucoma de pressão normal, baseado numa pressão 17, onde só tem aquela alteração da camada de fibra nervosa lá, assimetria, escavação maior no lado esquerdo que no lado direito, alteração da camada de fibra nervosa evidente no lado direito e campo visual normal.
Isso. Foi isso que foi na época.
Eu insistiria, o paciente não tem tanta noção da importância do OCT para esse caso, né? E o fato do convênio não pagar, eu acho eu entendo o que você está falando, mas assim, eu falo só, sinto muito o seu convênio que está errado, você tem que ter esse exame. Ele fecharia a questão aqui nesse caso, talvez você esteja tratando sem precisar. É um mal maior do que, embora eu acho que até precisa, acho que você está incorreto, não tendo, partindo do princípio que você realmente não tem OCT, ou o paciente não tem condições, ou não está trabalhando em lugar sem OCT. Mas, às vezes, o que a gente fala, parte da premissa é que, como o convênio não paga, sequer pede. Então, eu gosto de falar para o paciente, falar o seguinte, olha, o convênio não vai cobrir isso, mas o senhor tem que fazer. Aí acaba, 98% das vezes faz, porque é uma coisa importante para ele. Não vai fazer trocentos OCTs, mas eu acho que era importante colocar. Atualmente, o que a gente tem, inclusive com a Sociedade Mundial de Glaucoma, um caso como esse daí, um dos principais anos é o OCT. A gente conta da ANS, que ainda não aprovou, o óbvio que já existe há mais de 10 anos, né? Mas tudo bem,
eu acho que ele foi buscar o latanoprosto no governo.
Sim.
Buscar na farmácia popular o latanoprosto.
Isso. Aí vamos lá.
Eu acho que é importante o que o Augusto colocou, né? A gente passar para o paciente que ele precisa desse exame. Para uma boa medicina, a gente precisaria do exame e a responsabilidade a gente divide com ele, né?
Aí o que acontece com o paciente 2 anos depois? Aquele em 2017, eu acho que talvez vocês notem aqui, continua aqui, mas olha o que apareceu agora aqui, ó, em 2019. Já
Aí
veio.
agora, sim.
E usando latanoprosta, hein?
E usando latanoprosta.
Reduziu o quê? Uns 30%, né?
Reduziu um pouco, foi. Então, aqui na Red Free está mais evidente que aqui tem agora e em 2017 não havia.
Sim.
E o nevo, agora, olha o nevo. Se a gente ficasse
Agora-
só no nevo. 2017 e 2019. A gente olha e nada.
É porque assim, está sugestionado por conta da data, né?
Você devia tirar a data.
O vaso ciclo linear inferior aqui próximo da rima parece que está mais distante da rima. O ciclo linear superior não dá para ter certeza, não aumentou um pouquinho aqui.
Eu achei que superior aumentou também, mas está com a data.
Mas
né,
eu estou sugestionado pela data, né?
Tá bom.
Podia ser o contrário, né? Tal.
A gente graduava as fotos lá em San Diego sem data.
Já tem estudo mostrando que quando você sabe da data, você tem uma tendência maior de achar que está piorando.
Sim.
Bom, Luiz, então o tratamento não estava bom.
Não estava bom. E aí a gente vai ter que fazer alguma coisa. No olho esquerdo não encontrei nada para ele, né? Em termos de progressão. E aqui o exame dele em 2019, tá? Do campo visual, inclusive, é o 24.2C, né? Com aqueles pontos a mais do 10.2 aqui, que no lado direito pegou nada.
Olha, você pega uma coisa, né, o Luiz? Se a gente tivesse, por exemplo, lesão temporal inferior, para mim é condição de fazer um 10.2. Todo paciente tem lesão temporal inferior, eu faço um 10.2. Esse paciente tinha uma lesão temporal inferior, eu faria um 10.2. Aqui, nesse caso, o central mostrou que tem mais alteração central aqui no olho esquerdo, embora não era o olho esquerdo que tinha lesão temporal inferior, mas eu faria dos 2 olhos. Você voltando no tempo, você faria um 10.2 naquela época para aquele paciente?
Sim, faria sim, Augusto. Não sei se eu iria encontrar alguma coisa, porque os principais pontos do 10.2 estão aqui no 24.2C, né? Tem uns pontos a mais aqui, ó.
Sim.
Mas eu estava, mais ou menos, né? Tem um trabalho mostrando que, eu não lembro se metade dos pontos quando você faz a correção por deslocamento lá das células ganglionares, eu acho que é metade dos pontos como é que chama? Do programa C, estão fora dos 10 graus centrais.
Tá.
Então, assim, quando você mede, andando de 1 em 1 grau, 2 graus no 10 graus, no 10.2, eventualmente você vai pegar mais, com certeza vai pegar mais ponto mesmo. Eu tenho isso aqui, depois eu tento compartilhar. Tem isso numa aula.
Esse campo que você mostrou agora, que tem essa área central, foi depois do Reut superior?
Foi, depois do Reut superior. Está com os 2 Reuts no lado direito, superior e inferior, e não pega.
Tá.
Vamos lá para o segundo caso agora. Paciente de 58 anos, sexo masculino, também não usa antiglaucomatose. E uma coisa agora que é comum de a gente pegar, pacientes que foram operados no passado de cirurgia refrativa, né? No caso, ele fez LASIK em ambos os olhos há uns 15, 20 anos e não tem história familiar de glaucoma. A câmara era profunda, né? A córnea estava boa, sem alterações do LASIK e tal. Gonioscopia aberta, até o esporão escleral, sem anormalidades, e chegou na consulta, estava com pressão de 18 nos 2 olhos e tinha medidas prévias, escritas anteriormente, uma de 11 e outra de 14, cada um dos olhos. E aí veio com... Esse é o aspecto do olho direito, esse é o aspecto do olho esquerdo. Paquimetria de 525 e 525. Deixa eu voltar aqui.
O direito está sofrido já, hein?
Já tá.
Tem Reut, tem
Reut.
Tem um afinamento superior também, né?
Tá bom.
Esse é mais fácil, Luiz.
Esse aqui ficou mais fácil, né?
É o que a gente acha, né?
Não, mas então, aqui ficou mais nítido aqui né, pela retinografia aqui, temporal inferior, uma alteração. No lado esquerdo, eu não vejo alteração na camada de fibras nervosas. Eu não sei se vocês conseguem enxergar alguma coisa aí. E aqui tem o OCT dele, né? Que deu os parâmetros aqui, uma alteração arqueada temporal inferior no lado direito. No lado esquerdo não pegou nada, tá?
E é bom para mostrar a pizza desse aí, hein?
Sim, então tem lá, só tem esse lugarzinho aqui, marronzinho, né? Ou amarelo, desculpa, mas está aqui bem nítido.
Bem nítido, aí tem a radiografia.
Porque está aqui, né? E o olho esquerdo a gente não viu nada, pelo contrário, tem até um aumento da espessura nasal e nasal inferior, tá? Mas o que chamou a atenção é uma pressão intraocular baixa com a medida no Goldman. No paciente que tem LASIK prévio, que a gente sabe que vai hipoestimar a medida do Goldman, né? E aqui na complexo células ganglionares, né? Na análise de células ganglionares, a gente consegue observar no lado direito esse tipo de alteração. Campo visual, 2018, também passou liso, né? Pegou, não aconteceu nada.
Tem um esboço de degrau nasal ali, né? Tudo bem que está mais no pattern, mas está aparecendo.
É isso, né? Tem um esboço aqui.
E você tinha um Reut inferior, né?
Sim. Né? Tem essa diminuição.
Isso era... Ah, bom, tá certo, esse carro tá certo.
Então, entrou com latanopróstata, pressão reduziu e vamos seguindo. Agora vamos para o último caso. Paciente de 58 anos, sexo feminino, raça amarela, estava usando no passado, usava brimonidina, parava, depois usava latanopróstata, parava, aí veio encaminhada, já tinha submetido a facectomia em ambos os olhos, tinha uma história de cefaleia pulsátil e uma irmã portadora de glaucoma. Então, ela estava com a lente no local, nos dois olhos, direitinho, o ângulo aberto, pressões de 12 e 3 milímetros. No momento, ela estava sem usar medicação e veio com esse aspecto aqui, do nervo óptico do lado direito, e esse aspecto do nervo óptico do lado esquerdo. Vocês querem comentar algo que chama atenção?
Tem uma diferença de forma das papilas, né?
Tem uma alteração importante nasal no olho esquerdo.
Nasal do esquerdo.
Vamos lá. E aqui é no lado esquerdo.
É como se quase um note nasal, assim, esquisito, né? Isso não é uma coisa de... Não parece glaucoma, isso. Parece alguma coisa...
Ótimo. E aqui a gente percebe bem as estriações da camada fibronerval. Chega
e aqui nada, né? Isso, nada.
Aparece.
Rola um campo aí, Luiz.
Rola um campo. A mesma coisa do lado de cá, tá? 548 e 539, olha o campo dela.
Não, esse nervo do olho esquerdo, agora não vale mais, né?
E aí? Também teve defeito.
Tem um bitemporal head, né?
Não, na verdade, aqui eu fiquei com a hipótese de uma hipoplasia focal aqui do...
O olho esquerdo lembrava mais, né? Como o Augusto tinha chamado a atenção.
Então, aqui é a foto. A gente tem o acompanhamento dela seriado desse paciente ano a ano. Aqui eu coloquei de 2012 a 2019. Aqui, olha, o zoom da retinografia, 2012 e 2019. Eu olhei aqui e não vi alterações que me chamassem a atenção, assim, dizendo que estava progredindo ou não. Só me veio, sim, a parte de hipoplasia nesse lado aqui, supranasal, no lado direito. Já no lado esquerdo...
Você tem OCT macular, não?
Não, aqui eu tô... Nessa aqui, na verdade, eu tenho um OCT dessa paciente que mostra que tem alteração nasal superior, um afinamento da camada de fibras nervosas.
A gente viu no ambulatório, semana passada, um caso muito parecido, sugestivo, né? Ele está fazendo exames de hipoplasia superior, né, com um defeito altitudinal. Ele está examinando ainda para ver, mas é muito parecido com esse, só que superior à hipoplasia.
Então, eu mostrei aqui o histórico de 2012 a 2019, sem usar a medicação, e está aqui a alteração dela em 2019, que permanece a mesma que estava
muito interessante.
Com aquela...
Ela tem OCT?
Oi?
Ela tem OCT?
Eu não trouxe aqui, Augusto, eu trouxe OCT, eu veio com OCT de fora, tá? Da camada de fibras nervosas e estava alterado superior e nasal.
Nasal importante, assim, e não tinha descolamento também, não, né?
Não.
Como se fosse uma fosseta, não tinha, não, né?
Não.
Mas também nunca vi descolamento para nasal, assim. É sempre para...
Periferia da retina era normal?
Oi, perdão?
Periferia da retina é normal?
Sim, periferia da retina é normal.
É importante... Mostra o campo de novo, Luiz, já que a gente está encerrando já. É importante chamar a atenção, né, que esse defeito temporal, né? É muito raro o glaucoma começar desse jeito, né?
Nunca vi.
Então toma cuidado, tá? Se vocês olham separados, às vezes até grampeado, vira uma folha para lá, outra para cá, acha que tem defeito bilateral, né? Tudo bem, é bilateral, só que ele é bitemporal, né? Então precisa encontrar outras razões que não glaucoma. Tem temporal edge descrito em glaucoma? Tem, mas abrir o caso com temporal edge, ainda mais bilateral simétrico, né? Não é uma coisa muito comum.
Não. Luiz, posso compartilhar aquele negócio dos 10 graus centrais?
Claro, por favor.
Então, você precisa descompartilhar aqui.
Vou descompartilhar aqui, peraí.
Tem uma pergunta, Luiz, enquanto o Augusto põe, de um dos residentes, se isso pode ser hipoplasia segmentada no nervo óptico.
Exatamente isso.
É exatamente isso, né?
Ok, Luiz, esse trabalho mostrando que quando você faz a correção, qual é o importante desse trabalho? É quando você vê o que você está olhando no OCT e o que você acha que você vai achar no 10.2. E você fazendo isso para o 24C. Para o 10.2, você tem, assim, aquela correção, você já tem muitos pontos do 10.2, a despeito do deslocamento de célula ganglionar pelas fibras de Henle, você vai encontrar na região que é analisada na elipse do OCT. Agora, no caso do 24C, metade dos pontos está fora da elipse que é analisado de complexo célula ganglionar no OCT. Então, por isso que eu achei bem interessante isso daqui, o tanto que a gente está fora do que a gente vê de defeito de célula ganglionar no OCT quando a gente está fazendo análise só pelo 24.2C. Eu acho que a gente ainda vai fazer muito 10.2 a despeito do 24.2C. Era isso daí.
Bom, então...
Analisa a frequência disso, Paranhos?
Não, isso é 100%, né? Desculpa.
Não.
Todos os pacientes que fazem 24C, metade dos pontos estão fora da região da elipse.
O que isso representa clinicamente na grande maioria dos casos?
Como?
O que isso representa clinicamente na grande maioria dos casos? A questão é, se a Humphrey decide dessa forma, depois de um monte de análise, será que realmente, do ponto de vista clínico, isso é raro, a gente perder esses casos, ou será que nós vamos perder com muita frequência?
Vamos colocar assim, quando é que uma das indicações de fazer o 10.2 é quando você tem alteração na região dessa elipse. Então, não acho que fazer o 24.2C quando você tem uma alteração nessa região da elipse se justifica que metade dos pontos está fora disso. Não quer dizer que o 24.2C ele não tem utilidade para fazer avaliação central. Agora, quando você pega como é que fala? Você está se baseando na alteração do OCT para ver se pede ou não pede um campo visual central, ter feito o 24.2C não bastaria. É isso que eu estou querendo dizer.
Bom, gente, então eu trouxe esses 3 casos aqui justamente para mostrar a importância da propedêutica da camada de fibras nervosas, né? Então a gente às vezes fica focado só no nervo óptico e se não dilatar para poder examinar com cuidado, mas passa liso, assim, né?
Bom, vocês nem acreditaram como eu passei o Graham inteiro quietinha, né? Porque foi muito bom.
Nossa, Nilva, você tá aí?
Foi muito bom. É que você me viu a carinha aí, porque se não tivesse visto minha carinha, claro que eu saí. Mas
carinha e mensagens aqui.
Olha, eu fiquei muito feliz foi muito legal a participação da Duke, e o que eu fiquei muito impressionada é que o time inteiro deles estava lá. Né?
Tinha pelo menos glaucoma, córnea e úngula, pelo menos.
Participaram e conversaram. Eu achei fantástica esse nosso Grand Round. O time do glaucoma está de parabéns, foi fantástico. E o Franklin...
Eu também fiquei quietinha, Nilva. Eu também fiquei muito quieta.
Mas você eu vejo sempre, né? Eu sempre vejo você.
Elas não iam aguentar. Elas não iam aguentar.
Não, de jeito nenhum. Bom, então, apesar da gente ter avançado 9 minutos no tempo, acho que foi bem válido, foi muito bom. Eu agradeço todo mundo a participação, Luiz Alberto, Ivan por ter conduzido. Boa noite a todos e até a semana que vem. Feliz Dia dos Pais atrasado para todos os pais aí.
É isso aí.
Tchau.